Dr. Vitull Gupta and the organizing committee for giving me this opportunity to be part of this prestigious conference, MAPICON. So today I had discussed with Dr. Vitull Gupta. He said that you should present something. So I thought that I told him 3, 4 topics. So he said reduction in maternal mortality is this is the one which is most important for everybody to know. So I chose this topic. This was actually my study, which was conducted in AIIMS Bathinda. It was the topic of the study was also to reduce the maternal mortality related to postpartum hemorrhage. And as we know the background, the maternal mortality, when a young mother dies, it is not a loss of family only, it is a loss of nation. So it is very painful when we see any young mother, she dies because of a preventable cause. Preventable cause is mainly the postpartum hemorrhage. So we feel very sad. And we all know that the maternal mortality is the death of women during pregnancy, which should be celebrated. Pregnancy should be celebrated because it brings a life into the world. But when it is converted, death happens. So it is converted into mourn. So within 42 days after the pregnancy or for any cause related to or aggravated by the pregnancy or its management, it is called maternal mortality. And maternal mortality ratio in India has constantly declined from 333 in 1990 to 97. This is the latest data. And the target sustainable development goal is to reduce it to 70 by 2030. But Punjab, we know that it is a well-fed state. Still, the maternal mortality is 203, which is higher than the national maternal mortality. So, being in Punjab, it is our responsibility to reduce it, and at least from the preventable cause, which is a postpartum hemorrhage, which is leading cause and accounting for around 25 to 30% of the 35% of the maternal death. So this is overall global cause of the maternal death, and out of that the hemorrhage is responsible for around 27% of the deaths. So when we think of the other states in in India, the Kerala has the least maternal mortality, that is 19, Maharashtra 33, Tamil Nadu 54, and where we stand is 105. So this is very very sad that in Punjab, compared to the other states, we are in very bad state. So what is postpartum hemorrhage? It is defined as any amount of blood loss which is sufficient to compromise the hemodynamic stability of the mother. And by WHO, severe PPH is if the blood loss is more than 1000 ml within 24 hours, and by RCOG, it is major severe PPH is more than 2000 ml loss. But it is not only the amount of blood loss, it is the rate of blood loss, which is if it is more than 150 ml per minute, that is important. And loss of 50% of blood volume in 3 hours, that is important. And loss of 100% of blood volume in 24 hours, that will lead to maternal mortality. And global burden of PPH, you know that nearly 25% of the maternal deaths are due to PPH, and PPH affects around 5% of the women, and majority of the PPH associated deaths are preventable, as I already said, by prophylactic drugs during the third stage of labor and by rapid and appropriate treatment for the women with PPH. So what really kills a woman? There are 3 delays which we have encountered because of MDSR surveys going on all over India in each state. One is delay in diagnosis, another is delay in transfer of the patient to appropriate facility, and third one is delay in treatment and management. And 3 factors which affects, that is amount of blood loss, rate of blood loss, and health status of the women. Health status means that if the pregnant patient is to start with 6 gram only hemoglobin at the time of delivery, then even 400 500 ml blood loss may kill her because she doesn't have any reserve. And if the pregnant, at the same time, if the pregnant lady is having HB of 12 gram at the start of the labor, then she may tolerate even up to 2000 ml of blood loss. So can we prevent these? Yes, yes, we can prevent by providing a standard care of management of PPH. So thinking of this background, we planned a study. The study was prevention of postpartum hemorrhage related maternal morbidity and mortality through structured approach. And this was a pilot project which was started in two districts of the Punjab, that was Bathinda and Faridkot. This project was funded by Directorate of Environment and Climate Change, Government of Punjab under Mission Tandurust Punjab, and it was implemented in our department and by the Punjab Council of Science and Technology. The principal investigators from Bathinda and the Faridkot. So, the aim of the study was to reduce the maternal mortality by technical interventions and capacity building of the healthcare worker in the government health sector. And objective was to sensitize and train the peripheral health worker about the prevention and management of PPH, and to train and equip them with the uterine balloon and anti-shock garment, which was the two technical interventions which we are using to reduce the maternal mortality. So this was the project rationale, and we managed around 75 mothers, 26 in Bathinda and 50 in Faridkot, which were affected with critical PPH, and we were able to save 74 out of 75. And this study was divided into three phases. First was the pre-intervention phase, second was the intervention phase, and then the post-intervention phase. In pre-intervention phase, we collected the data from these two districts on three major parameters, that was maternal mortality data. What it was done by the assessment of verbal autopsy forms to identify the cause of death and identification of the PPH related death in the last 3 years, and assessment of the knowledge of health worker regarding the implementation of evidence based guidelines in the management PPH, and the assessment of management approach being followed in the health sector. So what we found, that we have total number of deliveries happened in Faridkot and Bathinda was 7,200 in Bathinda and 6,263, and there were total 27 delivery points which were monitored, and baseline data on 175 maternal deaths were collected in these two districts on 3 years data, that was 2018 to 2020, and total death review was done, and it showed that 50% of the deaths were the deaths due to PPH was 48, that accounted for 27%, and PPH related deaths 50% occurred in the tertiary care hospital, 10% died on the way to hospital, and 40% died at the level of PHC, CSC and private, and 29% patients which were received in the tertiary care hospital were in irreversible shock. So what was the reason for delay? There was a reason at home level in 29%, because the patients were even in the modern era were managed by DICE, and there was a deficiency in transport in 20% of the cases, and at the facility level, because of the lack of equipment, resources and manpower, 30% of the deaths were at the facility level. And knowledge of healthcare worker were assessed, and which show that except gynecologist, no other healthcare worker were aware of the uterine balloon and anti-shock garments. And PPH management approach was assessed in these centers, and only medical management was done at private sectors, peripheral health centers, nothing else was done. So then we came to the intervention phase after this background data, and there were two bundles were formed. The first bundle response was a clinical response. So all the health centers were trained about the uterotonic drugs, isotonic fluids which were given, and tranexamic acid is the latest WHO introduction into the management of PPH, which was also told, and they were told to do the uterine massage in every patient. And if with these medical management patient is not improving, then the response was to shifted to the refractory PPH bundle, which included the compressive measures like aortic compression, bimanual uterine compression, and two new uterine techniques, that was uterine balloon and anti-shock garments. These were delivered to all the delivery points in these two districts. And then we created a technical component of the intervention phase, that was teamwork and communication. We made a WhatsApp group of all the gynecologists and nurses, and facility readiness was done at every point, and network integration was done. Whenever any patient had PPH, they will put up in a WhatsApp group that this patient is being referred to the so and so center, and that center people were ready to manage with the blood group and all facilities at the center level, and data monitoring and quality improvement was done, and their leaders were selected from each area to implement this project. Then the first intervention we introduced was uterine balloon. Uterine balloon, I mean the baseline behind this was that standard modality of PPH was injections only to stop the bleeding, and if the injections are not able to stop the bleeding, then it was followed by hysterectomy. If the bleeding, but patient continues to bleed if she is referred to higher center, because hysterectomy facility is not available at PSC, CSC. So on the way, most of the patient die, or they are I mean when by the time they reach the hospital they are in irreversible shock. So uterine balloon was an intervention. When the patient is referred, it is very easy to introduce into the uterus, and this will act as a tamponade to stop the bleeding, and by the time patient reaches the hospital, the bleeding stops and the patient also doesn't go into shock. So we in India these type of balloons were available, which were made in America. That was Bakri balloon, and that was costing around 5,000, and it is available only in the higher centers and big city. So we proposed a very cheaper alternative, which is a uterine balloon, and that is costing only 700 rupees. So this is a balloon which we proposed. It was introduced by Dr. Burke. It is called ESM UBD device because every second matters in PPH. That is why name of this balloon is. So these are the components of balloon, which is which is available in a packet with a syringe and the condoms, and even gauze piece is there, and O-rings and Foley's catheter is there. So this is the methodology to introduce the balloon, and once we introduce the balloon, it will fill the uterine cavity and act as a tamponade. And the success rate in the various studies was shown that it is able to control uterine atony in 87%, and vaginal deliveries 87% PPH was controlled. Placenta previa also the rate was very high to control PPH, and even in accreta it was 66%. The second intervention we introduced was non-pneumatic anti-shock garments. These garments were these garments are actually originally designed by NASA. They are the anti-gravity uniform which were developed to keep the astronaut from blacking out during the extreme acceleration by squeezing the arms and legs to push the blood towards the head. So WHO recommended it as a temporary measure in PPH unless appropriate care is available. And NSG is included in the WHO, UNICEF and others list of medical device for essential intervention in the reproductive maternal child health. So this is how it improves. In obstetric hemorrhage, the mainly blood loss is from the pelvic area. So this blood loss will reduce the blood circulation to the brain, heart and lungs, which are deprived of oxygen because blood accumulates in the lower abdomen in the leg. So an anti-shock garment will reverse this by pulling the blood to the upper part. So anti-shock garments buy critical time to transfer a patient to the healthcare and provide the treatment. So this is how it is applied, and it has a 6 component, 4 around the legs and 1 around the abdomen, and abdominal component has a aortic ball which will press the aorta. So, and after 2-3 hours when the PPH is controlled, we can remove the anti-shock garment after checking the vitals. The impact of anti-shock garment was studied in 36 publications were there, which shows that it is able to reduce the maternal mortality to the tune of 69 to 68%. And these are the various studies. So in the intervention phase, once we brought this anti-shock garments and the uterine balloon, we did so many workshops at various places, all the health points in the Bathinda and Faridkot, and we delivered these anti-shock garments and balloon to all the states. And after the intervention, we collected the post-intervention data on 75 mothers, and 75 mothers these intervention were used, and we were able to save 74 mothers out of 75, and no hysterectomy was done. So the uterine balloon alone was used in 42 patients, anti-shock garment was used in 25, and both were used in 7, and total 74. and post intervention death review was done, which shows that out of total 86 deaths which were reviewed, the deaths due to PPH was only 9, and all patient died in hospital, no patient died in the periphery, because peripheral patients were referred to the hospital with these interventions. So this is the comparison of pre-intervention and post-intervention death review, which shows that from pre-intervention death, maternal mortality due to PPH from 27%, it was reduced to 9%. So there was 2/3 reduction in the maternal mortality with these two interventions. So we recommend that uterine balloon tamponade and anti-shock garment should be used in all cases of PPH, and training and workshop to be conducted at all delivery points in Punjab, and replication of this should be done in all area of Punjab to achieve the zero mortality, maternal mortality in PPH. So with the grand success of this pilot study, the government of Punjab was very happy, and they have sanctioned us a grant of 88 lakhs to replicate this project in 10 districts of Punjab. So the topic of the new project is management of PPH related maternal mortality in multi-centric holistic approach involving 10 districts of Punjab. So with these words I say that God cannot be everywhere, though, therefore he created mothers, and it is our duty that we must save them. So with these words I thank you very much.
Thank you very much, ma'am. Great lecture as well as great initiative, which is going to go a long way to save numerous lives. As Punjab is in the middle of maternal mortality rate, and your endeavor in replicating in 10 more districts will save many lives. Any questions or comments?
Thank you, sir.